In this session, I will define postmenopausal bleeding, its causes, how to evaluate a woman coming with the postmenopausal bleeding, and how to manage that woman. Menopause is defined as a permanent cessation of menstruation due to the absence of functioning follicles in the ovary occurring after 45 years. If the same phenomena occur after 40 years, it is called early menopause, and if it occurs before 40 years, it is called a premature menopause, or nowadays it is renamed as ovarian insufficiency. Postmenopausal bleeding is defined as bleeding occurring after 12 months of the last menstrual period in a woman after 40 years in the absence of pregnancy or lactation. Any unscheduled bleeding after 6 months of starting HRT or postcoital bleeding in a postmenopausal woman is also taken as postmenopausal bleeding. It is different from abnormal uterine bleeding and should be considered separate. The etiological classification of FIGO for AUB, the palm-coin sign, will not hold good for postmenopausal bleeding. The causes and hence the significance is different from AUB. In postmenopausal women, it is important to exclude malignancy. About 7 to 10% of the women with postmenopausal bleeding may be harboring a genital malignancy. Of this, important is to exclude malignancy of the cervix, uterus, and the ovary. Ovary, especially functioning ovarian tumors like granular cell tumor or theca cell tumor. Rarely, malignancy can occur in the vulva or vagina, and still it can be due to secondaries from other sites like breast, thyroid, or in the bowel secondaries. 1 to 3% of the women may have hyperplasia of the endometrium. So when evaluating the woman, the most important is to exclude malignancy and hyperplasia of the endometrium. The most common cause for postmenopausal bleeding, about 70 to 80%, may be due to atrophic vaginitis or endometritis due to lack of estrogen in the menopausal woman. Endometrial polyp is not an uncommon cause, especially it can be there in patients with recurrent postmenopausal bleeding. In women with long-standing prolapse, that may lead to decubitus ulcer. Vagina being very thin in the menopausal woman due to estrogen lack, it will be easily traumatized, and coital trauma is not so uncommon. Another important cause is drugs. These women may be in the middle age or in the 60s or 70s, may be on antiplatelet drugs, may be on anticoagulant, or she may be on prophylactic tamoxifen therapy. She may be on hormone replacement therapy. All these can present as postmenopausal bleeding. Rarely, you may come across a woman who have put an IUCD or pessary for a long time ago and have forgotten about it, which may later on lead to postmenopausal bleeding. Bleeding PV, here to be, sometimes it will be very surprising to know that the woman may be actually having a bleeding per rectum or a bleeding from the urethra or hematuria. In such cases, we had to exclude carcinoma of the rectum, piles, prolapse of the rectum, or in case of hematuria, any prolapse of the urethra, any urethral polyp or urethral caruncle. Coming to the evaluation of woman, first and foremost is a history. Ask for any symptoms suggestive of malignancy like loss of weight, loss of appetite, or early sanctity. Age at menopause. What is her previous menstrual cycle? And any history of abnormal uterine bleeding in the perimenopause or reproductive age, and how was it managed and what was the diagnosis. Regarding menopause, the age of menopause, what is how long is the postmenopausal bleeding is amount and the number of episodes, any history of previous evaluation, any history of drug intake, in intrauterine device insertion or accessory use, any history of mass per vaginum, any history of malignancy to the woman or in the family. In examination, the BMI, especially whether she is obese or not. Look for significant lymph node enlargement, especially of supraclavicular, axillary, and the inguinal node. Any mass in the abdomen, enlarged uterus, or a mass in the abdomen may suggest a pyometra or a fibromyosarcoma, or it may be an adnexal mass. Look for any presence of ascites. Local examination, look for any prolapse. And look at the urethra for any prolapse, polyp or caruncle. Any vulval growth present or not. Look at the perineum. Look for any prolapse of the rectum, hemorrhoids, and pus speculum. Look at the vagina, whether velocities are present or if it is thin and atrophic. Cervix for any growth, ulcer, and the size of the cervix, and whether it is hard and indurated or not, which may suggest a carcinoma or malignancy of the cervix. By manual examination, look for the uterine size, mobility of the uterus, presence of an adnexal mass, and deposit in the pouch or ovaries. Transvaginal sonography is the initial tool for evaluation of a woman with the postmenopausal bleeding. It is simple, cost-effective, and even avoid unnecessary invasive investigations like endometrial biopsy or hysteroscopy. In the sonography, one has to look at the character of the endometrium, its thickness, had to look at the myometrium and the adnexa or the ovary. The endometrium in a menopausal woman is very thin and homogeneous and described as like a pencil line. If the thickness is more than 4 mm, that should be further evaluated. If it is less than 4 mm, the chance of endometrial carcinoma is less than 1%, and hence further evaluation can be avoided. If the endometrium is more than 4 mm, or even if less than 4 mm but heterogeneous or irregular in thickening, we have to go for a endometrial biopsy. It can be done even by a pipelli, or depending upon the patient characteristic, can be done in a theatre, with a fractional curettage. There are certain situations where the endometrial biopsy should be done under direct vision, that is using a hysteroscopy. Hysteroscopy is recommended if the endometrium is more than 10 millimeter thickness, or there is fluid in the cavity. The endometrium is irregular, or when you see there is a focal thickening of endometrium, and there is a presence of recurrent postmenopausal bleeding irrespective of the endometrial thickness. Woman on tamoxifen therapy having postmenopausal bleeding. All these cases is an indication for hysteroscopy. If there is fluid in the endometrium, that is also an indication for hysteroscopy. But at the same time, one has to remember there may be an abnormality or malignancy of the cervix, or stenosis of the cervix should be ruled out. In women with a normal cervix, we can do away with them. We have to do a pap smear, and probably an endocervical curetting will rule out malignancy of the cervix. But if the cervix is showing any growth, ulcer, or more than the size of the cervix is more than expected for that age, then she should be further evaluated by a directed biopsy and endocervical curetting. Directed biopsy may be in the form of a colposcopy, can be VIA or VELI, and if the suspicion is very strong, even we had to do a con biopsy. Then coming to the myometrium. Myometrium, most often there may be a fibroid, or may not be fibroid may or may not be there. But remember, fibroid will not grow after the menopause. Most often the woman may have already known there is a fibroid, and then you can look at whether there is any increase in the size of the fibroid, or the fibroid, the margin should be regular or well-defined margin. It may be hypoechoic or hyperechoic. If the margins are irregular or the vascularity is suspicious, further evaluation with MRI should be done to exclude a leiomyosarcoma. And remember, just seeing a fibroid, you should not jump into a conclusion that the fibroid may be the cause for postmenopausal bleeding. Most often, it may be an innocent bystander, and the cause may be something other than fibroid. Now we have to look at the ovary. If there is any adnexal mass, further morphology of the mass should be evaluated, whether it is a solid mass, cystic, or varying echogenicity, whether there is a simple cyst or a multiloculated cyst, is there papillary excrescence, the thickness of the capsule, is there any tumor on the surface, etc. And a Doppler should also be done for the vascularity. Any low resistance flow will be suspicious of a malignancy, and it can be further evaluated by Doppler. And if it is suspicion, you have to further go for other imaging techniques like CT, MRI, etc. In this context, we may discuss about some special situations which we may come across while evaluating a menopausal woman. Women who have a history of breast cancer may be put on tamoxifen prophylaxis. Tamoxifen is a selective estrogen receptor modulator. it is an antagonist of estrogen on the breast, while it acts as an agonist on the endometrium. So, in women who are long-term tamoxifen, there may be proliferation of the endometrium leading to hyperplasia and atypical hyperplasia, sometimes even leading to endometrial carcinoma. So, any woman on tamoxifen while follow-up should be specifically inquired regarding any history of postmenopausal bleeding. If it is there, it should be promptly evaluated by a transvaginal sonography and an endometrial biopsy. Another situation is when you take a transvaginal sonography in a postmenopausal woman with bleeding. There may be presence of fluid in the endometrial cavity. The fluid may be either serous fluid or pus, or it may be blood. And the fluid may compress the endometrium, and the thickness of the endometrium measurement may not be accurate. So the thickness should be taken excluding the fluid. And if there is any fluid, it's an indication for taking a biopsy, as well as had to exclude cervical stenosis as well as a cervical carcinoma. Another important situation we may come across is an incidental finding of endometrial or thickened endometrium. The woman may not have a history of postmenopausal bleeding. She might have been evaluated for any other causes like abdominal pain, and a scan was taken and you come across a thickened endometrium. In such situation, when there is no postmenopausal bleeding and incidental finding endometrial thickness, endometrium of more than 10 mm should be further evaluated with a biopsy. If it is less than 10 mm, she can be followed up. Since the causes for postmenopausal bleeding is different, management also may depend on the cause. If it is a malignancy, further evaluation for staging should be done and managed accordingly. If it is hyperplasia of the endometrium, it can be with atypia or without atypia. Without atypia, one can be treated with progesterone. Usually we prefer medroxyprogesterone orally. It should be given for 6 months. Or can be treated with local progesterone like levonorgestrel intrauterine, that is LNG IUS. Women with hyperplasia with atypia should be given the option of hysterectomy with the bilateral salpingo-oophorectomy, because the chance of developing endometrial carcinoma is roughly about 8%, and also the chance of coexisting carcinoma is about 43%. In case of polyp, a hysteroscopy removal is indicated, which can be used for diagnosis as well as therapeutic. And a polyp either may be, most often may be benign, but there is a rare chance of being malignant polyp. So, in case of polyp, hysteroscopy should be done, and the background endometrium should be sampled for presence of any malignancy. Atrophic vaginitis or endometritis, which is the most common cause for postmenopausal bleeding, is due to lack of estrogen. So, estrogen should be supplemented either systemically or can be applied locally. Usually, local application will be sufficient, either as a cream or a pessary. Then, usually estrogen creams are available, like Primarin. It can be or estradiol cream can be is available. It can be asked to apply twice in a week for 1 month. After 1 month can be reduced to once in a week and can be given for 3 months. Regarding recurrent postmenopausal bleeding, there is confusion as to when to call it as a recurrent postmenopausal bleeding. Bleeding persisting for more than the primary bleeding persisting is not called as recurrent postmenopausal bleeding. It should be evaluated. The primary postmenopausal bleeding should be evaluated and found to be negative, and then recurring after 6 months should be further evaluated. This time, after a transvaginal sonography, should be hysteroscopy directed biopsy should be taken to look for any focal causes which has been missed in the primary evaluation. If any cause is found, treat accordingly. If there is no cause is found, even a hysterectomy is justified for fear of any missing causes. Hysterectomy is indicated in atypical hyperplasia and also in recurrent postmenopausal bleeding as a last resort. So in conclusion, it is important to rule out malignancy and hyperplasia of endometrium in a postmenopausal woman with bleeding, even though the most common cause is atrophic vaginitis or endometritis. Remember, endometrial polyp is the most common cause for recurrent postmenopausal bleeding. And at the same time, keep in mind, there may be bleeding from the urethra or rectum, which may be mistaken for a postmenopausal bleeding. Thank you.